You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is August 14th, 2023. Our topic is allergy and asthma in the elderly. Our presenter is Dr. Gailen Marshall. He is the RF Phaser Triplet Senior MD Chair of Allergy and Immunology at University of Mississippi Medical Center in Jackson, Mississippi.
Everybody, welcome to Conferences Online in Allergy. Today is August 14th, a Monday, one of two presentations. Our first presentation is by Dr. Gailen Marshall, who is the RF Phaser Triplet Senior MD Chair of Allergy and Immunology at the University of Mississippi Medical Center. And he also, he's got many titles. I'll just go through a few of them. Executive Director in the Mississippi Clinical Research and Trials Center. He is the Vice Chair for Research in the Department of Medicine, mentioned Director Division of Allergy, Asthma, and Clinical Immunology. And lastly, Chief of Human Immunology and Inflammation Biomarker Core Laboratory. So with a lot of great titles there, we appreciate that Dr. Marshall is here today to speak to us on allergy and asthma in elderly patients. Thank you, Gailen.
Thank you, Chris. I appreciate it. It's really good to be able to do this again. I enjoy this topic that every year gets nearer and dearer to my heart, as I have now officially considered to be a geriatrician, and my internist at my last annual appointment asked me if I was interested in transferring to gerontology for my clinical care. So what that means to me is that these are issues that relate to me as a person, and my empathy goes up for the patients that I see that have this. And because our lifespan, at least in my generation, continues to increase, we're living longer, you're going to see more and more of these patients in your practice. And I think there are considerations that are very important. And so I'm happy to go through those with you today. These are my disclosures. There's really nothing that is conflicting with what I have to say today. We're going to look at the similarities and differences in incidence, prevalence, pathogenesis, and clinical presentation of asthma and allergies in elderly versus younger patients, and discuss unique challenges in both diagnosis and management. So I do this, we all know this, but I do this simply for a matter of definition, because in fact, if a European colleague was listening to us, she or he might have a little bit different perspective even on the definition of allergy, because for us as allergist immunologists, we think of allergy in the context of allergen-specific IgE. Others think of all the Jelen-Kunz hypersensitivity as being an allergic reactions, but we're very intentional in the discussion this morning about production of allergen-specific IgE with subsequent mast cell activation with exposure and the resulting inflammatory response. In the old days, we used to say 1 in 4. We got around to 1 in 2, and now, candidly, I think it's more common than it is uncommon that people that have chronic allergic conditions have late phase components that go along with it. Manifestations for organ-specific rhinitis, asthma, atopic dermatitis, maybe EoE, depends on the year, depends on the person having the conversation, but very few discussions about the increasing incidence of multi-organ allergic disease as a result of food exposure, drug exposure, and systemic exposures that can come from these stinging insects and other. Therapeutic approach, of course, is still avoidance whenever you can. Medical therapy that's still primarily designed at decreasing the sensitivity to allergic mediators, and allergen immunotherapy, which is to decrease the actual sensitivity to the allergens, and in the best scenarios that have been painted, the production of allergen-specific IgE.
Hey, Gailen,
Yes.
I'm sorry to interrupt. I don't know if you're advancing any slides. We are not seeing that.
Oh, I am advancing them. Oh.
Okay. Sorry to interrupt, though.
Oh no, I'm glad you did.
Okay.
Let's see if all the things that can go wrong are going wrong. So let's see if you're seeing that first slide. Does that advance?
It did advance.
All right, let me try this, the I'll try the slideshow approach, and if it doesn't, I'll go back to this screen.
Okay.
Does it still advance?
You're on disclosures right now. It hasn't left that one.
Okay, so I'm going to go back to
That
all right. This is how I'm going to do it for the rest. For whatever reason, it's not working in the other. So that's
okay.
fine. So we did this discussion. These are the special considerations in elderly. The allergic pathophysiology is more varied exposures because they've been around longer. Environmental exposures, dietary changes as we get older, things we can eat, things we can't. Polypharmacy, which it keeps getting redefined. The number keeps going up because virtually everyone takes all kinds of different extraneous things, not only prescription drugs, but over-the-counters, supplements, etc. Immune senescence, which interestingly enough was not even described. The term senescence, as it applies to immunity, wasn't described till around 1980. I was a medical student when they started doing this, and the greatest impact, though, is on neoantigens and immune regulation, less so on memory. And then secondary immunosuppression, which can come from comorbid disease or drug-related immunosuppression. The clinical manifestations that can mask or alter presentations, intrinsic nasal disease, concomitant lung disease, GI distress because our tummies get more sensitive as we get older, skin changes that occur that may not be related to IgE-mediated mechanisms. Drug-drug interactions, not maybe, but they will be more complicated because it's not just drug-drug, it's drug-drug-drug, herb-drug-drug-drug. All of these having potentials for interactions, and I have some specific comments toward the end of the lecture that will go along with this issue. And then the therapeutic approach, careful attention to phenotype of the specific clinical entity with the recognition that overlap occurs a lot. And then the issues related to drug intolerance, which increase with age, which many people, because the natural, for the younger folks in the audience, if you haven't yet, you will come to understand very rapidly that a portion of the new patient visits you'll see is someone who's had an adverse reaction to X. And because they've had that adverse reaction to X, particularly drugs, they will claim that they have an allergy to X. And many instances, particularly in the area of drugs, it's not an allergic reaction, it's a drug intolerance that actually occurs. From a pathophysiology standpoint, this is just sort of a summary of the immune changes that are seen in elderly individuals. That magic number of 65 is sort of going to get thrown out by the wayside because it's not the chronological age, it's the physiological age that really matters. T cells tend to go down, CD3 goes down, the CD4-CD8 ratio decreases with age, the naive cells decrease and the memory cells increase, probably not an increase in absolute number, but a relative increase in percentage because of the decrease in others. The CD19 positive D cells tend to decrease with age, but interestingly, natural killer cells, the CD1656 population increases with age. Again, depending on the paper that you read about this, some will claim an increase in absolute number, but more likely what it amounts to is a relative increase in concentration because of the decrease in these other cell populations, particularly in the peripheral blood. There have not been good studies in humans where they've tried to quantitate extravascular numbers of these cells, with the possible exception of the T and B cells that are seen in lymph node samples. And even in that case, it's CD3 and CD19. They're not going into the subpopulations. Cytokines you tend to lose over time, the IL-2, T cell growth factor, don't think of it just as a positive growth factor. It not only increases the T cell populations that are effector populations, it is necessary for induction of the regulatory population. So as that decreases, not surprisingly, the regulatory component begins to decrease as well. And the concomitant regulatory cytokines, IL-10 and TGF-beta, commonly decrease with that. Increased amounts of IL-4, IL-6, IL-1 beta receptor antagonists, TNF-alpha. So the holy trinity, 6, 1 beta, and TNF-alpha increase with age, as well as, interestingly enough, the support cytokine, in particular IL-15, which is a necessary support cytokine to keep NK cells happy. Immunoglobulins tend to increase in numbers. Now, this may be, in some instances, a false increase because viscosity of individuals increases with age. Old people don't drink as much as young people, by and large, because we don't have to go to the bathroom all the time. So we tend to live with a higher viscosity in that the osmolarity is slightly higher in older individuals compared to younger individuals. But interestingly enough, the other argument against that is that you would expect all 4 subclasses to increase. 1 through 3 have been reported to increase, but 4 does not. So perhaps there is an actual increase in the IgG production in older individuals. IgA goes up in the well, IgM remains stable, and IgE decreases with age. Environmental influences, global temperatures associated with incidence of allergic sensitization in the elderly. The higher temperatures are increased petrochemical pollution levels. This is particularly a problem in urban environments, but it's even a problem in relatively rural environments like we see here in Mississippi all the time, because ozone is just as prevalent in broader sense, if you will, in rural areas that are adjacent to or in the path of, if you will, urban areas as they are inside of the urbans themselves. The particulate matters, particularly PM2.5 and other reactive oxygen species, sensitivity to this increases with age and has adverse impact that is not necessarily related to allergy and asthma on cardiovascular, pulmonary, mucosal tissue, as well as I mentioned a moment ago, increasing plasma viscosity. It's also associated with a heightened and prolonged pollen season in our temperate climates. We're here in Mississippi experiencing the same thing across the nation with the high temperatures and the terribly dry humidity at the moment. But interestingly enough, our ragweed is here early. We usually see ragweed later this month. We're already seeing it, and it's up. So even with this hot, dry environment, this ragweed season is getting longer. Our tree and grass seasons are getting longer as well. This is common literally globally right now. Internal environments, housing of elderly is oftentimes not as clean, especially in an institutional environment. There's increased levels of house dust mite, cockroach, rodent, and pet dander. In the clinical spectrum of allergy in the elderly, we go through the organs and you'll see some interesting comments. In allergic eye disease, allergic keratoconjunctivitis is actually most common in the elderly. It rarely presents without other atopic conditions. So they need to have atopic dermatitis or rhinitis, which is going to be their most common presentation, or possibly asthma. The major differential is senile keratoconjunctivitis, bacterial, which can be a ocular emergency, as well as herpetic keratoconjunctivitis. I have never, again, those in the audience that don't know me very well, I have never in all my years, which is now coming up on 40 years of doing this, I have never written my first prescription for ocular steroids. Because when I was a fellow, I saw someone who came to the emergency room with herpetic keratoconjunctivitis that had been prescribed steroids by someone who was not familiar with this and did not know how to do slit lamp exam, and the individual had nice corneal holes and ended up having a corneal transplant. So that stuck with me all these years. When I'm worried that they need this, then I pick up the phone, call my ophthalmology colleague, and have these people seen urgently. And generally speaking, you pick up the phone and call the ophthalmologist, even though the average appointment for glasses is a year out. They'll see the patient the same day, even if it's the ophthalmologist in the emergency room. They will see them. Rhinitis, on the other hand, in history is key to the suspicion for an atopic component. The skin test is often indicated, but remember, responses decrease with aging. The major differential here is chronic non-allergic rhinitis. Vasomotor is probably the more common thing that you see, oftentimes in a mixed pattern with an allergic component. Don't automatically, because the patient is 73 years old, don't automatically assume that there's nothing allergic left in them, even though if they have a clear history that goes along with vasomotor. Ask a few more atopic questions. Rhinitis medicamentosum is seen in this population as well, not only from aspirin abuse, but from other therapeutic agents that can have rebound capabilities. Allergic skin disease, contact dermatitis is probably the most common. Chemical, fragrances, and heavy metals being really common antigens that can induce this. Atopic dermatitis is less common, but at least it still should be considered in new onset eczema in the older individuals. Uncommon rashes, drug rash, scabies are also things that have to be concerned. So given the fact, again, I don't know in your practice locale and our practice locale, our dermatologists are absolutely covered up with business, a lot having to do with cosmetic derm, cancer dermatology, etc. So getting these patients in to see the dermatologist to evaluate a rash sometimes takes some time. Us being able to do the differential and look this through and know their approach to therapy can be very useful in our older population. Chronic urticaria is less associated angioedema with this, fewer urticarial lesions. They can itch like crazy and may have what almost seem to be just a few scattered lesions, which are far worse for them. In this population, they would be somebody in their 30s or 40s. They tend to be spontaneous and less so due to physical or cholinergic factors. The infection is more common in the elderly, H. pylori and anisakis. So if they have the appropriate concomitant symptoms, intervention for this may be useful. 45% are associated with autoimmune phenotype. Highly common is the IgE receptor antibody. Aspirin and NSAID is greater in elderly, so you have to ask questions. We hurt more, so we take more NSAIDs. And oh, by the way, this can, in some instances, even apply topically. Some of these topical NSAIDs that are DMSO based, where they get across so they can get into the joints that ache and hurt. If there's enough applied, this can get levels that can approach those that are seen with aspirin and NSAID. And don't forget, of course, that the very common 81 milligrams of aspirin is still adequate in some individuals to increase their sensitivity for chronic urticaria. New onset, as opposed to recurrent chronic urticaria in elderly, is more associated with monoclonal gammopathy. I made a rule in my own practice years ago that if I see anyone 65 or older, again, there's that age, but in that category that has new onset urticaria, I get an SPEP to make sure that they don't have a monoclonal gammopathy. Angioedema, new onset HAE is exceedingly rare. It's if they therefore have an inhibitor deficiency, it's almost certainly an acquired, and you think about a workup for neoplasia or collagen vascular disease. The highest rate of angioedema is, higher rate of angioedema in patients taking ACE inhibitors. It's a little more controversial as to whether ARBs fit into this category. Sort of the general guideline that many of us go by is someone that has an ACE inhibitor-induced angioedema. We take them off. We look for something else beside an ARB to put them on. If their hypertension provider says, no, they really need an ARB, we suggest they be watched very carefully, because the numbers are somewhere between 10 and 15% of individuals seem to have trouble with ARBs if they've had trouble with ACE inhibitors as well. Anaphylaxis, there's no specific increase with age, more likely to be idiopathic or hymenopter related. Food anaphylaxis is distinctly unusual in the older population. However, morbidity, mortality is considerably higher in the elderly when anaphylaxis does occur, particularly because of underlying cardiovascular and pulmonary concerns. but also concomitant meds and polypharmacy. They may be on NSAIDs, they may be on beta blockers, they may be on ACE inhibitors, etc., all of which can have an adverse impact on outcome if someone does experience an episode of anaphylaxis. Food allergy. The incidence is increasing worldwide and appears to occur in elderly as well. It's up to 5% of the new onset food allergy in adults occur in the elderly. Consider maintaining existing food allergy into later life versus new onset. Which is it? Is this someone who you're seeing for the first time, but they know they've had a shellfish allergy for the last 35 years? Or is this someone who was doing well until they went to the seafood restaurant last week, had shrimp, anaphylaxed, almost died, recovered, and a month later you see them in clinic, and sure enough, they have clear evidence of IgE against the shellfish that they consumed. The most common presentation in food allergy is GI, but anaphylaxis to food is much less common. As we talk about drug allergy in the older individual, ADRs are more common, but drug allergy is likely less common in the elderly compared to younger population. Yet, if the drug allergy is there, it's up to a 10% mortality risk, and that is because the elderly are less likely to survive an anaphylactic episode than the younger individual. Estimated that ADRs account for as much of 10% of geriatric hospitalization. Now, this is the totality of adverse drug reactions, of which drug allergy is a component, but is not the only component. The risk factors, though, that have been identified for drug allergies being female, frailty, physical frailty, various cardiovascular and cardiopulmonary comorbidities, polypharmacy. Culprit drugs are not substantially different from younger populations, so there is no identified drug, with again the idea of the NSAIDs not being IgE mediated drug allergy, but contributing to mast cell hypersensitivity in certain patients. Certainly something to be considered in your workup. Therapeutic considerations for efficacy. Antihistamines by and large decrease their effectiveness with time, and we're not talking about diphenhydramine with its strong anticholinergic effect. We're talking about true antihistaminic effects, and that is in some instances not only the histamine receptor changes, and so the receptor binding is different, but it's also because of the mimickers, if you will, of mast cell mediated reactions that are not mast cell mediated, that are not histamine mediated, and as a result, the antihistamines are not as effective. Corticosteroid is still the mainstay of controlling inflammation, ideally topically as opposed to systemic. Catecholamines continue to work for cardiovascular support, albeit with decreased efficacy. You still, I don't care if you're 18 or 88, in a systemic mast cell mediated reaction, epinephrine is still the first thing you reach for. The concern that the 88-year-old has cardiovascular disease, and if you give them epinephrine, they're likely to have a heart attack and die. Balance that with the idea that if they're anaphylactic and they're not breathing or they don't have blood pressure, what impact is that going to have on their brain, on their heart, and on their kidneys? Epinephrine's primacy in anaphylactic reactions, systemic allergic reactions, does not change. The side effect, of course, of therapeutic considerations often related to comorbid end-organ dysfunction. Antihistamines, again, anticholinergic and soporific effect. The non-sedating antihistamines tend to be more expensive, and with the exception of fexofenadine, if they decide to push the doses, even of the non-sedating antihistamines, they can get a soporific and possibly anticholinergic effects. Corticosteroids have adverse effect on bone density, diabetes, weight gain, skin thinning, glaucoma, cataracts, all the things they do in younger individuals. But realize as you get older, your bones thin out. You're more likely to become diabetic. You're likely to gain weight. Your skin gets thinner. Glaucoma is more common in my age population than your age population, as there are cataracts. The issues with polypharmacy we've already mentioned. Psychosocial, we have to remember memory impairment for therapeutic adherence. Even if it's mild memory impairment, as we get older, I can tell you, I drop a last name and or I can't remember somewhere that I went some years ago, and for a fleeting time I begin to wonder, gee, am I beginning to lose my mental capabilities? It's particularly relevant for me and my family history because my mother passed away with Alzheimer's. So I am at increased risk. What do? Many of our patients will simply cover it up. They'll cover it up. Oh, I just didn't get around to it. Oh, I forgot to do it, and so on. But an assessment of memory impairment is an appropriate part of the things we do for our patients with allergic and asthmatic disease. Affordability is a major issue, and then issues related to anxiety and depression, which can affect symptom perception as well as motivation to be adequately treated. What about immunotherapy? Again, we know what it does and how it does it, increasing immune regulation, decreasing allergen-specific IgE and allergen-specific IgG for whatever it is that it really does. Historically, age is considered a relative contraindication because of the belief that respiratory symptoms in the elderly rarely were IgE mediated, that elderly immune system was incapable of changing after immunotherapy, and a concern that increased mortality risk in elderly from systemic immunotherapy due to comorbidities. They've got underlying heart or lung disease or specific polypharmacy, ACE inhibitors, beta blockers, SSRIs, etc. And then there's evidence for efficacy of AIT in elderly is sparse, but there's even less evidence for lack of efficacy. And all the intent of this slide is to tell you, don't immediately say, well, you're over 65, I'm not even going to think about allergen immunotherapy with you. Think about them in the same context as you would anyone else that comes into your office and seeks your care. The epidemiology of asthma in the elderly, and I'm sorry this shows up better as a better slide than it does in this, but you'll get the drift of this. There's increase in prevalence similar to younger age groups, underreported and underdiagnosed, higher morbidity and mortality in the elderly population. It's often confused and see it with COPD, even in the absence of a smoking history, even with evidence of reversibility and overlap, is more prevalent in this age group than it is to the younger age groups. There are two major types. Early onset that continues into senior years are new onset after the age of 65. And if you look at the right side of this slide, in the early onset compared to the late onset, early onset's more likely to be atopic. They're more likely to be higher symptoms. The pulmonary function impairment is typically greater in early onset. The annual decline in FEV1, which occurs with all of us with aging, tends to be greater in late onset. The reversibility tends to be greater in late onset, and airway hyperreactivity seems to be about the same in both populations. The pathophysiology, immune senescence, again, regulatory and neoantigen deficiencies, resulting increase in inflammatory environment. The so-called inflammaging. If you don't know about inflammaging, you need to Google this, or actually better still, do a PubMed search on it. There's a very interesting mounting literature in geriatric immunologists about the origin and consequences and approach to therapy of inflammaging, and it's not the same as inflammation in a 30-year-old. The atopic component is much less, but it's not zero. It's usually considered to be about half, as compared to 50% of atopic asthma in adults, about a fourth of atopic asthma in elderly adults. And if they are indeed atopic, it's more likely to be the perennials rather than the seasonals. The dyspnea is the most common presenting symptom. Half report retrospective breathing difficulty years or even decades before diagnosis. You know, doc, you help me understand I have asthma and I've had this trouble. I feel better in breathing than I have in 30 years. I think any of us that have been doing this for any period of time can relate to patients that have that will present that history after therapy. Makes it seem important that we should be asking the questions earlier. Bronchiectasis is more associated with more severe asthma, a greater hospitalization rate, and the risk for chronic respiratory failure. So even an HRCT at times in someone who's got more severe asthma may be indicated to determine the level of presence or absence of bronchiectasis in a given patient. High air pollution is associated with ED visits for asthma exacerbations. So much so that in many of the urban areas, that those of you that live in urban areas, and I grew up and lived for many of my years in Houston, Texas, the 6 o'clock news report, if there was any sort of a respiratory, they used to have temperature, or I guess they still do have temperature inversions a lot in Houston, that makes the air pollution very severe. And there'll be announcements on the 6 o'clock and 10 o'clock weather reports about air pollution and people with respiratory disease, particularly older individuals with asthma, are warned to stay out of the environment. In terms of pathophysiology, looking at the asthma of the elderly, there's changes that occur essentially because we're just getting older, and there are changes that occur specifically because of asthma. The alveolar space gets larger because of aging, happens to all of us. The decreased elastic recoil pressure is decreased. The compliance of the chest wall and spine is decreased. It's harder for that that chest to stay open, so the compression is there more commonly. Premature airway closure and increased air trapping occur. But the asthma itself, there's a decreased elastic recoil pressure. So if you have compliance problem in the chest wall and elastic recoil pressure on the airway, you can get a double whammy in these elderly asthma patients. There's increased level of airway inflammation, oftentimes non-eosinophilic, and increased airway remodeling. The end result is more severe, difficult to manage asthma. You look at the immunity in terms of their impact in these individuals. In innate immunity, the peripheral eosinophilia and airway hyperreactivity in men is a little bit higher than women. This is from the normative agent study. The degranulation of peripheral eosinophils in older patients with asthma is actually less. It's not to say that they're more stable, it's just that their eosinophils are not as active, if you will, as they were eosinophils from younger individuals. Bronchial alveolar lavage fluid neutrophils and neutrophil elastase activity increases with aging in patients without asthma. So the sputum neutrophils in older versus younger patients with asthma increases, and sputum neutrophil mediators in older patients with asthma increases as well. In adaptive immunity, Tregs decrease in the periphery in older patients with asthma versus controlled subjects, same age but don't have asthma. So asthma is associated with lower Tregs in the elderly population. Pro-inflammatory cytokines, the inflammaging idea, increases with age, which can have an impact on asthma. And then in antibodies, there's a decreased antibody response to vaccines that occurs with aging. And we know that anyway, so it limits the effectiveness of particularly the antiviral vaccines. This is going to be a very interesting topic in the next several years as it relates to COVID vaccines and the recommendations that are going to come out. Is it going to be once a year for younger people? Is it going to be twice a year? Is there going to be a higher dose for COVID antigen for older individuals like there is now for the flu vaccine? All these are things that will be worked out, I believe, in the next several years. Diagnosis, common diagnostic criteria is valid in the elderly just like it is in the younger. The clinical presentation, dyspnea, chronic cough, it may be more subtle as it is often chronic, and it's either continuous or relapse or new onset. So you'll see people in their 70s that have had asthma since their childhood. You'll see asthma patients that developed asthma, it more or less resolved in their adolescence or early adult years, and then it relapses in later life. And then you'll see asthma patients that never had a stick of asthma before age 67, and they come into your office with new onset asthma. They often present with comorbidities that confuse the diagnosis. Remember, we've all seen congestive heart failure present as so-called cardiac asthma, which is really tricky sometimes in a patient that has concomitant asthma and they also have congestive heart failure. Hence, listening at their bases for crackles is a worthwhile thing to do, even if you can hear them wheezing in the mid to upper airways. Diabetes and renal insufficiency, because of their impact on various systems, including the cardiopulmonary system, can have impact to confuse and obscure the proper diagnosis. And then concomitant smoke exposure, either primary or secondary, looking at the possibility of COPD versus overlap, and without the recent emphasis that we, even as allergists, immunologists, are seeing in patients with eosinophilic COPD, probably again in that overlap component, it becomes important in the diagnosis we would make if the individual is older. Further discussing, there's a typical prejudice to move to COPD even without a strong smoking history. Lack of initial reversibility does not always indicate irreversibility. For many of us, we were taught that if somebody comes in the office and you see them and they have clear obstruction and there's no reversibility, unless they are in their 70s and have been smoking for 50 years, you don't assume it's COPD without giving them a trial of systemic steroids, somewhere from a week to a month, depends on the practitioner. Bring them back, repeat the spirometry or the pulmonary function test, and look for reversibility before you call irreversible. That's all fine and good, but there's still these concerns about the systemic steroid treatment and repeat spirometry in the older population because of the increased comorbidity of these systemic steroids. Mental status becomes important. Older individuals have a higher rate of anxiety and depression that can affect disease perception and severity. Altered symptom perception, either from the chronicity, they have had it for so long, they're just used to it, or inactivity. They would be terribly out of breath if they tried to go and walk, but they essentially stopped walking years ago. They go from their chair to the bathroom, to the bed, to the chair, to the bathroom, to the bed, and their inactivity can oftentimes mask their symptom perception. Other comorbidities, the resulting physical decondition, as well as the limited inactivity, interstitial lung disease, etc., can have an adverse impact. Diagnostically, you want to start with the history. It can be inaccurate because of recall bias or their reluctance for candor, as we've previously discussed. The exam itself, pertinent negatives and positives are even more important. I'm a big believer in pertinent negatives anyway, but they're even more important in this population than that might be in some of the younger population, because the lung itself may seem to be normal in its initial exam. Pulmonary function spirometry versus complete PFTs, that's not only relevant in terms of the burden you're putting the patient on to go get the PFTs. They usually have to leave your office, go somewhere else. The burden of doing full PFTs as opposed to being able to do spirometry in your office, but the value of full PFTs, you have to weigh that. And then the final part of this, by the way, is the payment for it. Is for a lot of the Medicare programs, if you do spirometry in your office, they're not going to pay for PFTs and vice versa. They won't pay for both. You have to pick that one. And it becomes important when you determine what information you're trying to get out of this test for your patient. Imaging itself, CT versus HRCT, I think most of us would opt toward HRCT unless there was some specific inclination for the regular CT itself. But you're looking for bronchiectasis, structural abnormalities, and interstitial processes, which indeed might simply have you end up sending this patient to a pulmonary colleague for consultation. When you look at the issues here, are these things going down this list in elderly versus young? Spirometry may be less useful with frail patients. Bronchodilator response may be less pronounced. Exhaled nitric oxide may be useful in both categories. The methacholine challenge is used left often because of more frequent contraindications, particularly cardiovascular disease. It's more useful in the young population. Atopy is less common. Comorbidities, as we've discussed, COPD, heart disease, phenotypes. There's a limited knowledge about this, but it's mounting, and I'll show you something in just a second. Late onset asthma, long-standing asthma, and ACOS, that really should be ACO described, and there are multiple phenotypes described as well. Sputum cellularity is generally more neutrophilic and is generally more eosinophilic in the younger asthma population. Allergy testing should be considered as the history suggests. lower blood IgE, skin test is less responsive. So immunocaps are going to be lower in older individuals simply because there's less serum IgE. The labs, CBC with DIF, looking for eosinophilia, that total IgE can be significant even if it's mildly elevated because that number decreases with age. Asthma control tests, there's some special considerations. The dyspnea line, what about deconditioning versus interstitial lung disease versus actual obstruction? They simply fill out what the line says, so that may lower their score. Nighttime awakenings could be from their asthma. It could also be that they got to get up at night because they have to go pee, that they have obstructive sleep apnea, that they wake up because they're anxious, or they have problems with primary insomnia, all of which increase with age, and all of which are important for you and me as providers to query our patients on. It takes time to do that. Bronchodilator abuse can be done from habit, from an altered perception, or because they have vocal cord dysfunction, which in fact they think that the albuterol makes them better, and there's some reports that suggest that that might even be true, but not necessarily because of poorly controlled obstruction. And then quality of life could be decreased because of lifestyle, anxiety, loneliness, etc. So someone who's doing well, if they're asthma, but they have some of these other comorbidities, might have an asthma control test score of 15 or 16, which if we saw that in somebody who was 50, we would be very worried that they were a inadequately controlled asthma patient bordering on poor control. Phenotypes in the elderly, persistence from childhood, as we mentioned, or early adulthood, late onset, overlap, dominant versus asthma dominant is important. That really has to do more with reversibility and inducing factors, and then atopic versus non-atopic are all phenotypes to be considered in the elderly. What about management? Basic principle is the same. You take care of them just like you would others. Control inflammation, treat bronchoconstriction, maximize quality of life, and minimize adverse effects of therapy. The challenge for this in the asthma population of the older is defining safe, effective management, treating the right disease, the phenotypic heterogeneity. Allergy shots in a 70-year-old are worthless if they are not atopic. On the other hand, if the allergy component is significant in a patient, you don't automatically disqualify them just because they're 70 years old. Environmental control issues, which can be challenging from a social standpoint, socioeconomic issues, which progress with age, and pharmacotherapeutic issues, all of which we've described. The environmental control, allergen versus pollutant, dust mite, insects, particularly cockroaches, pet dander, mold, because pets are their companions. The challenge is once in a while you'll see an older person that loves their cat, but unfortunately their cat allergic. And their asthma doesn't do well when their cat climbs up in their lap, but they love their cat. They're not going to get rid of them. This is a therapeutic conundrum that is not nearly as rare as some might think. Urban pollution, particularly during the summer, toxic fumes from cleansers, paint, etc. It's often difficult to maintain good environmental control. The expense of the air quality improvement, buying a HEPA filter and replacing the filter, high quality AC filters are expensive. And people on fixed income, it's difficult oftentimes for them to be able to afford this. Physical limitations for dust and mold control just because they can't get around. Commonality of indoor pets, as we just mentioned, and even hygiene issues that can promote cockroaches, rodents, and mold growth. The socioeconomic issues, people tend to get more isolated as they get older. Because of mobility limitations, support structures often shrink with age. Outside interests tend to wane. Physical comorbidities, kyphosis and sternum convexity increases the AP diameter, which can decrease the respiratory muscle strength. All of this can contribute to a easier to describe dyspnea that these individuals get with non-asthma related causes. Asthma elasticity, airway elasticity diminishes with age, reducing the respiratory flow. The ratio goes down naturally with age. Sedentary lifestyles increase physical deconditioning. And then the psychological comorbidities, cognitive abilities, the paradox of well-being. the high level of life satisfaction with lower level expectations. Anxiety and depression alter concerns about addressing symptoms. It's what difference does it make mentality. And then disturbed sleep that can have adverse impact on asthma control. Polypharmacy costs, drug interactions, distaste and concern about adding more medications, not uncommon. Cognitive decline, remembering to take the right meds at the right time and the right way. Poor recognition of adverse effects. This medicine is keeping me awake. Well, I just don't sleep well. Further cognitive impairment. Physical limitations, coordination from using MDI or sufficient respiratory efforts for DPIs versus the value of just using a nebulizer. Ability to hold breath for sufficient periods of time, dysphagia in pill swallowing, and then specific consideration for pharmacotherapy may be more susceptible to side effects at regular drug doses. Anticholinergics may be more effective for pure asthma in the elderly, even though it may well not be pure asthma, and the leukotriene modifiers may actually be more helpful. There are reports to suggest this. What about biologics? Studies for current available, omalizumab reported to age 75, mepo to age 68, dupi to age 80. Theoretical limitations, IgE decreases with age, so maybe omalizumab might not be as effective. Eosinophils increase with age but have less specific activity, so maybe mepo, benra could be more effective with aging. IL-4 increases with aging, so maybe you should use dupi. There are arguments for all of these, but the fact is that when you look at this was a paper published now about 4 years ago. They looked at tezepelumab is not on this list, but they look at omalizumab, mepolizumab, reslizumab, benralizumab, and dupilizumab. And what you're looking for is smiley faces to say that it actually is better in elderly. Benralizumab for lung function, benralizumab for exacerbations, benralizumab for symptoms and quality of life, benralizumab for side effects. You see some of these with omalizumab. One would argue from this that you should be using benralizumab in all your older patients, but this data really does not support that, but it points out the relative amounts of things that are there. But the most important things are these little things, is that there's lack of data for many of these. And the lack of data lack of data for efficacy is not data for lack of efficacy. It doesn't go both ways. And then finally, pharmacologic considerations that we discussed, just sort of summarizing. Inhaled corticosteroids, the cytochrome P450 inhibitors that they may take in other cases can increase bioavailability and risk for toxicity. If you have prolonged co-administration of enzyme inhibitors, the alternative approach is the choice of a corticosteroid that is metabolized through hydrolysis. So in older individuals, beclomethasone may be better based upon their concomitant pharmacotherapy. It's worth looking at. We can't ignore it. We have to look at it. Systemic steroids, again, the long-term adverse effects. Theophylline, if you have a P450 inducer, it increases the clearance. If you have a P450 inhibitor, it increases the risk of side effects because it decreases the clearance. And for those of us that are old enough to know that we used to have to use theophylline all the time, this was a major concern, and it's why you don't find a whole lot of asthma patients on theophylline anymore. Beta-2 adrenergic agents increase the activity of sympathetic nervous system. The result can be a downregulation of beta-2 receptors, as we all know, and then the cardiovascular side effects of the beta-2 agonists. The anticholinergics, dry mouth, pupillary dilation, blurred vision, the side effects are a major concern. The leukotriene receptors are less effective than in young people, receptor antagonists. Specific immunotherapy can work in some individuals, but I think we've talked about that in detail. And then omalizumab suggesting improvement of exacerbations in individuals over 50. This is a slide that sort of summarizes everything that we've talked about. And that is, as we get older, there are more concerns related to the cofactors that have more heterogeneity in the presentation, multifactorial exacerbation, and more socioeconomic burden which then means we need a better multidimensional approach to care for these patients because of long-term prognosis, pathogenesis, and endotypes, which we didn't even mention today because of the controversy associated with it and trying to sort it out, and then the precision medicine that we're all moving into as we practice later into the 21st century. So in summary, we say the presence of allergy and asthma is relatively common in elderly population. Diagnosis can be challenging, but must begin with clinical suspicion. And management can be challenging because of increased side effects, polypharmacy, and physical and psychological impairments. Reported morbidity, including ED and hospitalizations, is lower, but mortality is higher. We must address these patients in a fashion that recognizes common and unique situations for them to craft effective and personalized therapeutic programs. And with that, I appreciate your attention, and in the few minutes we have left, happy to answer any questions.